Dr. Neha, over to you.
So we're ready to go.
Recording in progress.
Good evening, everyone. I'm Dr. Neha Sinha, coordinator for this KAP series. It gives me immense pleasure to welcome you all to this another interesting session of KAP Knowledge, Attitude and Practices in Anesthesiology. In today's session, we are going to have very interesting case discussions by private practitioners across the country. And also, we're going to have a panel discussion on group practice in anesthesia. So to begin with, I would also like to thank Mr. Rahul Chaube from Anaesthesia TV for making this for making this live and reaching this content to so many people. So to begin, to start with, not wasting another moment, I am going to invite the moderator for this KAP series, Dr. Naveen Malhotra, sir, a name that needs no introduction. Good evening, sir. Sir is professor and head. Sir is professor and head at PGIMS Rohtak at Department of Cardiac Anesthesia and Pain Management Center at PGIMS Rohtak. His major achievements include he is Deputy Chair AARS WFSA, Honorary Secretary SARC AA. Sir is a recipient of ISA Bhopal Award for Academic Excellence 2015. Sir is a recipient of KPR Young Anesthesiologist Award 2009, KOP Award for Trauma and Critical Care in 2001. Sir has a whopping 216 publications and 426 presentations. Dear ISAians relate to him as our own secretary. We all know that Sir has expanded, Sir has given us opportunities as a secretary, and he has introduced us to so many vast areas in academics as well as another aspects of anesthesia. His areas of interest are chronic pain management and cardiac anesthesia. We welcome you, sir. I would now request sir to speak a few words. Over to you, Naveen, sir.
Thank you, Dr. Neha, for those words. And it's really a pleasure to welcome you all to today's very important session, which is divided into two parts. One is the presentations by the private practitioners. We have amongst us our own Dr. Rituja Chopra and a youngster from Punjab. And then we will have a very important panel discussion on the importance of group practice in anesthesia. Why group practice anesthesia? How and how to overcome the challenges. So I'll hand it back over to Neha to carry forward the proceedings. I welcome you all to today's KAP Academic Series session, which is the fifth one in the P20 series, which is dedicated to the private practitioners across the country. And I know it has generated lots of interest and enthusiasm. Thank you all for your active participation. I also place on record my deep sense of appreciation to Anaesthesia TV and Mr. Rahul Chaube for live streaming it on YouTube, Facebook, and other electronic media handles. Thank you very much. Over to you, Neha.
Thank you so much, sir. So moving on, I would now like to invite our chairperson for this session. Our chairperson for this session is Dr. Harjinder Kohli. Good evening, ma'am. Ma'am is a senior consultant at Deep Hospital and Children's Clinic in Ludhiana. Her major achievements include she is a teacher of DND anesthesiology at Oswal Hospital and SPS Hospital, Ludhiana. She has various presentations and guest lectures at various state and national level conferences. Ma'am is an AHA certified ACLS and BLS trainer. She has 7 publications in national journals. Her areas of interest are obstetrics, trauma, regional, neuro, acute and chronic pain. We welcome you, ma'am.
Thank you, Neha. Thank you. And I'm privileged to be a part of these series.
Thank you so much, ma'am. Moving on, I would now like to invite our first speaker of the first speaker of today's session. Welcome Dr. Ritu Chopra, ma'am. Ma'am is a senior consultant and head of department at Jindal Institute of Medical Sciences, Hisar, Haryana. Her major achievements include PG DHM Code Blue Coordinator. She is a DND faculty. She is President City ISCCM Hisar, Vice President City ISA Hisar. Ma'am is has an Everest-based camp check, TMC 42 kilometers, Tufman Mashobra Ultra. Her areas of interest are critical care, Code Blue, Onco-anesthesia, swimming, cycling, trekking, and running. That's very, very varied interests, ma'am. That's amazing. We welcome you to the session, and I hand over to you for this, to carry on with the lecture.
Thank you, Neha. Thank you so much, Neha.
Thank you, ma'am.
This is.
Ma'am, you can now share your presentation.
Is my screen visible now?
Yes, ma'am.
Okay, hi. Good evening, friends. It's a wonderful feeling to be sharing this forum with such distinguished and esteemed colleagues. In my MD days, we didn't even have a separate cancer OT, what to say of cancer hospitals. But in my career spanning 18 years in Jindal Hospital, maximum airway mishaps have occurred in Onco-OT, and secondly, I think nowadays in ENT-OT. I have selected few cases where by timely and intelligent intervention, I would say, catastrophic events were averted. Obviously could not capture the images, as you all can imagine the chaotic situation that whenever there is an airway failure in OT. So I try to recapitulate from my own memory. So obviously my topic is on onco-anesthesia and airway challenges. As you can see in this picture, the road is tough, terrain is very difficult, but with proper gear and equipment and technical skill, one can overcome any challenge in life or in operation theatre. So the challenges are very obvious. These are multiple patients that I was able to get images from. It is very apparent the airway is almost shared or in very close proximity to the surgical field. My initial few slides are, I've just given these initial few theoretical slides for to give an idea to our younger audience and to make them aware regarding airway issues faced during oncosurgery. We all know what a burden cancer is these days, and we are only third after US and China. And in 2022, there were more than 14 lakh cancer patients in India. Only due to tobacco, mortality was 3,500 people per day. And one woman dies of cancer cervix every 8 minutes. So you can understand the burden from all these figures. Head and neck cancers are among the top 10 malignancies globally. So what is different with oncosurgery? We all know these patients are immunosuppressed, and the very diagnosis of cancer makes a person depressed, probably leading to nutritionally challenged in a way. Malignancy per se is a hypercoagulable state. There is multi-organ involvement, more so with widespread metastasis. There is a marked inflammatory response, which makes post-op care also very difficult. Many of oncosurgeries are very prolonged surgeries these days, and hence the time of anesthesia also gets prolonged. And there is always an unexpected blood loss during any surgery. So what are the oncosurgeries with the possibility of a compromised airway? All head and neck cancers, including thyroid, larynx, pharynx, squamous cell carcinomas, maxillectomies, all oral cancers procedures varying from laser excisions to hemiglossectomies to wide local excisions to probably local or free flaps, radical neck node dissections, mediastinal tumors, carcinoma lung, carcinoma esophagus. So what are the basic issues that we face with oral or head and neck cancers regarding airway? Firstly, the cancer growth itself might hamper our airway. There might be anatomical changes over due course of the disease progression, or fibrosis due to prior surgery or radiotherapy. There might be restricted mouth opening with a limited neck movement and extension. The surgery might be there might be a flap, or reconstructive surgery might be in plan. Airway edema due to surgical manipulation many a times makes extubation very difficult. Bleeding risk either due to surgical manipulation or probably multiple attempts at intubation. and in the end, there's always a risk of pulmonary aspiration. So what are the anesthetic concerns regarding airway in such patients? Bag mask ventilation is almost difficult to impossible in few patients. Tumor growth, we all know, is very friable, so it can fracture and dislodge. Malignancy, tumors prone to bleed. There might be an unappreciated tumor extension to base of tongue, causing tongue fixation, which somehow either we or the surgeon are not able to evaluate preoperatively. Poor dentation in patients, and again, there might be fibrosis due to prior radiotherapy. So, coming to the cases, first cases, it was a case of lap esophagectomy and a known case post-CTRT. The CT was suggestive of downstaging of tumor, which was abutting the left bronchus. During mobilization of cervical esophagus, suddenly there was EtCO2 suddenly went zero, and with a subsequent fall in saturation. So the first thing that would come to an anesthetist's mind would be probably a disconnection of circuit or some malfunction in the workstation. Immediately, tube placement, malfunction, everything was checked, but everything was in place. And we were not able to ventilate the patient with a bag also. So actually what had happened was, while mobilizing the cervical part of esophagus, there was a posterior tracheal wall injury, which the surgeon himself kind of suggested to me because I didn't know where he was during the course of surgery. So the first thing that came to my mind was to probably just move the tube a bit ahead and to probably just send it into the right bronchus. But with the rent, I might have just, the lower end of tube might have just abetted on the rent and further widened it. So immediately we had to do a fiber optic bronchoscopy through the tube, and the tube was subsequently repositioned into the right main bronchus. We were able to ventilate the patient with one lung ventilation. So the tracheal vent was then later on visualized, which was extending into the left bronchus. It was so low and from just above the carina and extending towards the left bronchus from posterior side of the trachea. So the cardiothoracic surgeon was involved and a pericardial and latissimus dorsi flap repair was done. This patient was uneventfully discharged on 11th post-op day. This is second case. This was a 65-year-old patient on palliative care, CA base of tongue, and he was posted for feeding jejunostomy. Many a times we get such palliative procedures done under regional anesthesia. This particular patient was a chronic smoker with COPD changes. Post-CTRT, CT showed residual disease with inflamed bilateral AE folds, but not much of airway compromise in CT film. Mallampati grade 2, that is what the anesthetist told me, with fibrosis and edema definitely around the neck. The anesthetist concerned decided to proceed for general anesthesia since ejection fraction was also 30%, but could not ventilate, could not intubate. So there was definitely chaotic situation inside the OT. Call for help was sent out. Meanwhile, there were repeated laryngoscopy attempts. The patient started bleeding, ending up with bronchospasm also. When I came, so I could realize from the scenario that probably the patient might need to do a tracheostomy on the patient. Immediately asked for an open tract set or PCT, but again, meanwhile, hurried attempts at fiber optic intubation was done, but somehow that also failed. Saturation had already dropped under 10, so had to open the trachea with a stab knife, and an endotracheal tube was placed. The patient could be oxygenated, and after stabilizing, the endotracheal tube was replaced with a tracheostomy tube. After stabilizing the patient, the surgery continued and the patient was again discharged uneventfully. So in this particular case, I would like to point out that the CT film was dated 8 months prior to the surgery, and somehow the concerned anesthetist failed to check the date on CT film. So probably the disease had already progressed, and that's why we ended up with this scenario. Third case. This was a large multinodular goiter with suspicion of malignancy posted for total thyroidectomy. An awake fiber optic intubation was planned. Sedation was given with fentanyl 2 mics per kg, but disaster struck in the form of the video bronchoscope screen just went dead while inside the pharynx. Simultaneously, the patient started having breathing difficulty and went into stridor. Laryngoscopy performed, again, we failed to intubate the patient. Saturation dropped with bradycardia. emergency PCT had to be performed via a very lateral approach. This was a huge thyroid, and trachea was shifted to the right. A tracheostomy tube was placed through the cricothyroid membrane. This approach was so lateral that vascular injury could have happened, but in that emergency situation, there was no other option for us. But probably since we are doing a modified dilatation technique, percutaneous tracheostomy, so that was obviated. Ours is a very high volume tertiary referral center, but a charitable trust one. So what we usually get is patients from rural background with majorly financial constraints. These are the tracheostomy sets that we have. This is an arrangement, in fact, that we have made. The final two dilators and the white one and the metal dilator are from the tracheostomy sets that we newly opened. But rest of the dilators and guide wire needle are all from either CVP line sets or the dialysis line sets. So we prepare such sets and we get them either ETO or plasma. And we are doing almost 100 to 120 PCCs per month in our hospital. This was a gentleman. Somehow I was able to, I again did a emergency tracheostomy in this patient. This was a base of tongue patient and operated, kept on TPs for a day and then extubated the next day. But he went into stridor. I think there was tongue fall. The tongue was not, the tongue support had gone. So emergency PCT done, a very short neck, a very lateral approach for PCT as I think probably because of the flap. But again, were able to save life of this patient also. So this was the procedure done on this gentleman. Somehow I was immediately able to ask staff to capture the images. Obviously, I gave local initially, and this needle was from the CVP line set. The guide wire is also from the CVP line set. We use the first screen dilator from the CVP line set, but in this particular case, somehow the staff managed to let it roll down the trolley. So I had to use the second dilator. Otherwise, we prefer not to use blade also, since there's always a chance of an innominate artery vein somewhere, and we might be injuring that. So the whole procedure takes probably 1.5 to 2 minutes in a skilled hand. You can hear the patient is in stridor here. Very short neck, a fatty patient with a lot of edema because this is just second day of surgery. Need to be very careful while dilating, since we might do any other injury apart from just dilating the trachea. So this is the very high of tracheostomy and very lateral also. So definitely there have been complications also during emergency airway manipulations, like bleeding, hematoma, subcutaneous emphysemas. But we all need to know what might go wrong and what we can do to obviate these major complications. False tracheostomy, false passages while putting a tracheostomy, posterior tracheal wall injury, esophageal perforation, pneumothorax, obviously ending up in either cardiac arrest or death. So what can we do to probably optimize? There's this term rehabilitation now, as we had rehabilitation earlier. So in rehabilitation, we can go for nebulization, incentive spirometry, chest physiotherapy. We can optimize the medical conditions like diabetes, hypertension, some coronary vessel diseases. Can ask the patient to stop smoking. Even a 24-hour cessation of stopping can reduce 8% mortality. The one most important factor is proper assessment of airway in PSC. Actually, this is where most of us fail. Nutritional assessment, if it can be corrected, ERAS programs should be brought in hospitals in a very structured manner for all the different surgeries. So the take-home message today would be, again, a very proper, detailed preoperative evaluation regarding airway, a readiness to perform tracheostomy preoperatively. We might have saved many patients if the surgeon would have probably not hampered our decision to do a tracheostomy preoperatively. If in doubt, do go for a radiological assessment. 3D CT scans are available these days. One should be very adept at PCT, fiber optic bronchoscopy, so do master your skills. Supraglottic airway devices, fiber optic intubation, PCT sets, open track sets should always be available. Do call for help early. Don't hesitate. Don't let your ego come in the way. And anesthesiologist skill, judgment, years of experience do matter a lot. The informed consent and preoperative counseling, including explaining complications in detail and to ask the attendants to give it in their own handwriting, is very important. And perhaps we can do a videoscopy also of this counseling. Learn to say no sometimes. Heroism does not always pay. When I was a freelancer in private practice, I have ended up in soup because probably my ego told me not to call for anyone, and how could I say no to a surgery? And do always expect the unexpected in onco surgery or in any other surgery. Thank you so much. So if we are skillful, if we have done all our preoperative evaluation properly, so probably we can give this winning pose. This was at the end of 42-kilometer Tata Mumbai marathon. Thank you so much.
Thank you so much, ma'am. That was indeed informative and very motivational as well. So I would now like to invite Dr. Harjinder Kohli ma'am to start with the discussions, please.
Yeah, indeed, very challenging cases she has been discussing, and each and every airway management was very precise, and but one thing was that she had always a plan in hand, because she's versed in doing onco-anesthesia. She's been doing for so long, and yes, a call for help. And one thing, never lose your cool. Never lose your cool. Be calm. The things would automatically turn out to be good. So really challenging cases. And I just wanted to ask one thing: is percutaneous tracheostomy advisable in an emergency situation?
Ma'am, I'll tell you what, because most of the times I think everyone is aware there is not a surgeon in the OT when we end up with an airway failure. And I am more of a critical care person. Definitely anesthesia is still my first love, but I'm more into critical care. So in fact, most of us in our hospitals are very adept at PCTs. So at times when there seems to be a difficulty, we do ask the surgeon to be in the OT at the time of induction. But otherwise, just in case the surgeon is not present and unexpectedly we fail to secure an airway, then rather than an open tracheostomy, I would go for a percutaneous tracheostomy.
Yeah.
Like
this
you saw,
what
this
we
was
have
also an
always
emergency.
been learning. Yeah. Hello, can you hear me?
Hello, yeah, ma'am, can hear you.
Yeah. So I think the first thing that you told, that preoperative assessment of the airway, that is very, very important, and one must not miss it. Another thing is that disease always progresses, as you have told in one of the cases. So never hesitate to ask for a fresh CT or to discuss with your surgeons. Surgeons should be equally responsible, a part of our team, and the teamwork here is very, very important. Never hesitate to call for help, as you have told early. Make a good team. The surgeon needs to be always there to help you out. And yes, your peace of mind, your backup plan, they're very, very important. Discussing with the attendants, discussing with the patient, taking them into good confidence, spending time with them, because orally they are all emotionally, psychologically drained out. So I think that gives a lot of edge. That making a rapport with the patient is very, very important in these patient and the attendants also, so that they have that faith in you. Yeah.
Can I add something else, ma'am? We also go for an audits in our hospital. So whenever such a kind of a mishap happens, if there is no scope, obviously you can't be doing anything. But in case there's a mishap where probably something was missed, so we do go for internal audits also. Yeah. It's not a blame game, but just probably what we could have done better in this case, or how it could have been prevented.
Yeah.
That's a policy too in our hospital.
And each of them is a learning experience in itself. Each of these cases, guides you for your future such like cases or maybe worse than these. So it's itself a learning experience for all of us.
Thank you, ma'am. Before moving on, I would like to invite our chairperson for the evening, Dr. Virendra Sharma, sir. Good evening, sir.
Thank you. Good evening.
Good evening, sir. Sir is a consultant anesthesiologist at Vivekananda Polyclinic and Institute of Medical Sciences, Lucknow. Sir is the treasurer at ISA National, chief coordinator for Private Practitioners Forum ISA, coordinator ISA Financial Advisor. He's the past governing council member of ISA National.
Reporting in progress.
Chief coordinator ISACON 2018, joint organizing secretary ISACON, past Central Zone Secretary ISA, past UP State Secretary ISA, and past Lucknow City Branch Secretary ISA. We welcome you, sir.
Dr. Neha, there is a question in the chat box for Dr. Ritu. And
yes,
what has to be done if there is subcutaneous emphysema? Dr. Ritu?
Yes, sir. Sir, first thing is we get an X-ray done, and it's better to put a chest tube. Now that the needle thing that was done is no longer advised, and usually if the airway is secure, we don't worry about subcutaneous emphysema. It settles down with time. Only thing is the patient's look does look grotesque, but you just have to counsel the patient's attendants. That is it. So if there is no pneumothorax, you go for nothing to be done. But on the safer side, we do put a chest tube at times. Otherwise, nothing is to be done.
Thank you. Dr. Anupam, you have raised hand. If you want to ask question to Dr. Ritu Chopra, most welcome. And I must say, Dr. Ritu Chopra has managed these cases very, very nicely. She is an icon of Fit Anesthesiologist campaign also, as has been shown that she has gone to the base camp of Mount Everest. She is a vivid runner. 45 to 60 kilometers is nothing for him and Dr. Jasuja. Both husband and wife, Devinder, and they both are very, very ardent to the fitness. So it was pleasure interacting with you, and
thank you.
Welcome Dr. Virendra Sharma, the chairperson for the session, treasurer, past treasurer, ISA National. Dr. Neha, we can move to the next presentation, please.
Right, sir. I would now like to invite our second speaker for today's session, Dr. Navneet Sandhu, ma'am. She is a freelance anesthesiologist working at various hospitals in Amritsar. Her major achievements include she has a fellowship in bariatric anesthesia from Max Hospital, Delhi, and also a fellowship in palliative care. She has attended various workshops on difficult airway management and ultrasound guided blocks. She has a paper in Indian Journal of Anesthesia. Her areas of interest are painting, for which she has received various awards, both national and state awards. We welcome you, ma'am, and I hand it over to you for your presentation.
A very good evening to everyone.
Ma'am, you can share your slides.
My screen is visible to everyone?
Yes, ma'am.
Okay. My slides are visible?
Not yet, ma'am.
Okay. Actually, I will be joining from another ID for that.
So by the time you join, I'll request Dr. Virendra Sharma, the chairperson, and Dr. Rajinder Kohli to say a few words. Dr. Rajinder Kohli and then Dr. Virendra Sharma, please. Navneet, if you can speed it up, because we are going for a panel discussion also. Okay. So please log in through your laptop. Dr. Rajinder Kohli, few words from your side.
Yeah. So I must say this is a great platform for all the private practitioners where they can address their concerns. And in the last few series that I have, seen or I have attended, I have seen that many of them have started coming forward. There was always an inhibition. I mean, I tried my side also to get some private practitioners to, speak up for our local CMEs, but nobody was coming forward. They were always hesitant. But at the end of it, they're doing brilliant work in their areas with those resources which are limited, and at the spur of the moment, the decisions that they take, they have been doing cases wonderfully. But this platform truly is one where the academic concerns can be shared, and I think it's a brilliant idea and a good vision by Dr. Naveen. And it is always good to find new faces, the younger ones who are coming forward with their presentations, with their experiences, with their skills. It's really good to have all those new faces coming up now.
Thank you, madam, for those words. Dr. Virendra Sharma, please.
Thank you, Dr. Naveen. Good evening, all. I've been reading about this series, which is encouraging the practitioners to participate. Of course, this is the first time I'm attending. Actually, basically working in a private hospital, sometimes you do not know, there are no fixed timings and all, but it's very encouraging. We've been working for private practitioners. We revived the forum since 2017. But this is something new where, like as ma'am mentioned, no hesitation, they can present. It's not a big platform, means like a national conference where there is a lot of competition, your selection of paper and all. So I think it's a good work being done by Dr. Naveen to encourage youngsters to present and the practitioners also, their problems related to them. Like today we have a discussion about good practice and all. So it's a very nice initiative started by Dr. Naveen. And I wish all the best for the future programs. Thank you.
Thank you, Dr. Virendra Sharma. And because we have planned to start the panel discussion on group practice at 7 p.m. So still we've got some 13 minutes left. So we'll have to quickly run through the presentation of on the as early as possible. And Dr. Vivek Shluja, you can use this opportunity to invite, since by the time Dr. Navneet joins, to invite the delegates to the annual national conference, 70th ISACON 2023, which is going to be held in Gurugram, Haryana. Dr. Vivek Shluja, please.
Very good evening to everybody. I'm Dr. Vivek Shluja. I'm President of ISA Gurugram branch. And I take this opportunity to invite all of you to Gurugram in November. We are eagerly waiting and looking forward to receive all of you. We promise you an academic feast never like before, and not only that, we plan to give you some very good evening entertainment, being that Gurugram is the pub city of North India. So I think there are definitely a lot of things you can look forward to. So welcoming all of you for a very good academic feast and good times in the evening.
Thank you, Dr. Vivek. Dr. Monica Chikara, as a State Secretary of ISA Haryana, I request you to cordially invite the delegates.
A very good evening, everyone. As you all know that the national conference is happening in Gurugram in Haryana this year. So I would like to request you all to be a part of it and grace the occasion with your presence. And I promise you that it will be a very memorable experience for you all. Thank you. Hope to see you all.
Thank you, Dr. Monica. And we have got our very respected Dr. Tej Paul sir amongst us. Sir, a few words of advice from your side.
Excellent programs, Dr. Naveen. Always. Today is the best because the very young anesthesiologists are managing it in Dr. Neha, Harjinder, and Dr. Monica.
Thank you, sir.
Thank you so much.
We are happy that they are going to lead because they are the future leaders. And it is Dr. Naveen who is grooming them. This is a quality of an individual. The topic is very excellent. The airway management has been discussed very nicely by, I think it was Dr. Ritu. The speaker was Dr. Ritu. She did it very, very nicely. I wish all the best and best wishes for the national conference to be held at Gurugram. All the best. All the best.
Thank you, sir. So nice. Dr. Vineet, please unmute yourself. The Secretary of ISA Gurugram City Branch. And I'll request Dr. Sunil Sethi, GC member ISA National and co-advisor of ISAFON 2023 to please say a few words. Dr. Vineet, please.
Good evening, everyone. I am Dr. Vineet. I am the Secretary of Society of Anesthesiologists, Gurgaon. This is city branch of ISA. We have registered our branch last year only, but since we are running this branch from last more than 10 years, but it was registered last year. And this year we are holding this national conference. Thank you very much, Dr. Naveen, for your kind guidance so that we could get this opportunity to host this such a precious activity or program at Gurgaon. I invite everyone and delegates to please join this conference is good number. And as Dr. Saluja already told that we are not going to disappoint you in any aspect of the conference, be it academic or extracurricular activities or going out, your family, your kids, we will take care of everything. Thank you very much.
Thank you, Dr. Vineet. Dr. Sethi, please.
First of all, welcome to the chairpersons and the speakers for today. And we will be having a very good discussion. And it is very nice to see all these speakers from all over India. And good evening, sir. Dr. Tejke Kalse, sir. And it is, as everybody has said, this is an excellent platform designed by Dr. Naveen. And I appreciate his vision. And he has been working hard for everyone. And this platform is bringing younger generation, as Dr. Harjinder was telling, that the younger generation, those who were reluctant to be on stage, they are willfully coming forward and presenting their cases in this platform. And it is an excellent platform to present the cases. And one thing I would like to add, being Governing Council member from North Zone, I request everybody to register for the conference. And as Dr. Vivek and Dr. Vineet has told, under the able guidance from Dr. Naveen, this conference is going to be a different one, where you will literally say that this was a different conference. We will be concentrating more on video presentations, on workshops, and everybody will have something to participate. There are plenty of awards, plenty of scientific programs. So I request all of you to please come and to Gurgaon and grace the occasion. Thank you very much.
So thank you, Dr. Sethi. So Dr. Neha, I think we should be on time, and let's start the panel discussion on group practice. And I'll request you to please introduce the panelists and the chairpersons again. Dr. Neha, please.
Right. So moving on to the next part of the KAP series, we start with the panel discussion on group practice in anesthesia. So it gives me immense pleasure to welcome the panelists for this session. I would now like to invite Dr. M. Subramaniam, sir, MD, DNB, BA, and FRCA. Sir is head of Department of Anesthesia at Rainbow Hospitals Group. His major achievements include he was a visiting faculty at University of Michigan, Ann Arbor, USA. He is the founding director of Axon Anesthesia Associates Private Limited, which has been providing services to over 30 hospitals in Hyderabad, Bangalore, Chennai, and Visakhapatnam. Sir has been actively involved in teaching younger anesthesia doctors. He has been instrumental in starting fellowship courses in pediatric and obstetric anesthesia. Sir has various chapters in medical textbooks and published in journals. Sir is also the trustee of Rotary Club of Banjara Hills Charitable Trust, which operates Sparsh Hospice. Sparsh Hospice, it takes care of the end-of-life patients who have been struggling with cancer and related issues. His areas of interest are pediatric anesthesia and obstetric anesthesia. Welcome you, sir.
Thank you. Thank you very much.
Welcoming our next panelist for the session, Dr. Sunil N. Shah, sir. Sir is a consultant anesthesiologist at Ahmedabad and director at Creators Anesthesia Associates Private Limited. Sir is also the chief anesthesiologist at Bankers Retina Clinic, Netralok Eye Hospital, Modi Eye Care Hospital. His major achievements includes he is the president of Anesthesiologists Association at Ahmedabad. Sir is the recipient of H.M. Desai Best Paper Award for Private Practitioner at Surat and Baroda, and also the Gujarat State Branch Annual Conference. His areas of interest are pediatric anesthesia. We welcome you, sir. We've already heard a few words from Dr. Vivek, sir. We welcome you, Dr. Vivek, sir. Sir is head of the Department of Anesthesia and Critical Care at RV Hospital, Gurgaon. He's the visiting consultant at Apollo Cradle, Gurgaon, and Cloud9 Hospitals, Gurgaon. Sir is the ISA Gurugram branch president, past president in 2019 and 2020. His areas of interest are pediatric and obstetric anesthesia, and his special interest is management of critical care in the ICU with special interest in poisoning and toxicology. Welcome, Dr. Vivek, sir. Our next panelist is Dr. Vineet Gupta, sir. Sir is consultant anesthesiologist at Cloud9 Hospitals, Motherhood, Daffodils by Artemis, Apollo Cradle, and Art Fertility Solutions, Gurgaon. Sir, major achievements include Sir has worked in India and abroad as a leading clinician in dealing the cases of obstetric, bariatric, plastic, and reconstructive operative procedures. He has attended many conferences as faculty speaker, panelist, and has chaired many sessions as well. Sir has been writing articles on various topics of anesthesia for students under the name of Quick Dose. He is the present secretary of Society of Anesthesiologists, ISA City Branch, Gurugram. Sir's area of interest are labor analgesia and anesthesia, planning, designing of OT blocks, setting protocols, quality assurance, and team building. We welcome all the panelists for this session.
Thank you, Dr. Neha, for the introduction of the chairpersons and the panelists. So we quickly go into the issues pertaining to the group practice. See, at one stage or other, we have realized that we need group practice or not. So my first question straightforward to Dr. Vivek Saluja sir is, sir, group practice, is it really required? Your thoughts and opinion on that. Unmute yourself, sir.
Thank you, Dr. Naveen, for this opportunity. I entered practice in 2002. I came directly from All India Institute of Medical Sciences, and one of the first things I was told was that in private practice, you are your own consultant, you are the resident, and you're the junior resident. I had a good run at private practice. Until 2014, I was the leading practitioner in Gurgaon. But I saw my children grow horizontally. I never saw any of them grow vertically. Whenever I used to come home, they all used to be sleeping. And when I used to leave in the morning, they were still sleeping. And I thought that was it. That was enough. So in 2014, I started my group, which we call as Hypnos and Anesthesia Associates. Hypnos being the god of sleep. Since then, in the past 9 to 10 years, we have grown. And now definitely I feel that it was a good decision to start a group and share my work. Therefore, it is required for effective time management for both your personal life and your professional life. You're able to provide multi-dimensional services to all the hospitals, and it proves to be beneficial for all stakeholders, for the anesthetist and for the hospital owner or the surgeon whom you are providing service to. You have helping hands in times of need. Anesthesia is a stressful subject. It is a stressful profession. You never know when you might need help. And believe me, it is a good coronary dilator to know that there are 2 or 3 people you can call and they will come at once and not say that you've done something wrong. As a group, you have a recognized presence in the city and you are counted as something. You go to IMA meetings, unlike most anesthetists, you don't go and meet people. People will come and meet you and say, sir, how are you? Please come to our hospital. You can generate effective retirement or slow down plans. We have one senior member in our group who is deciding to slow down, and we offer a good package whereby he can work a limited hours, still get a remuneration, still work, and at the same time, he works according to his convenience. Social interactions within the group are possible. You know that there is someone with whom you can discuss things, you can diffuse self-tensions and doubts, and you don't feel alone. Therefore, at a certain stage also, you learn how to share knowledge and money. It leads to all-round personal fulfillment and satisfaction. And as you become more senior, your juniors accord you more respect and gratitude. And I think after a certain age, this respect is more important than the money you get. Thank you, Dr. Naveen. I think that is why group practice is necessary.
Strongly that group practice is required. I'll request Dr. Sunil Shah if you want to add something to it, or any of the other panelists or chairpersons who have their thoughts on whether we should go for group practice or not. Most welcome.
Naveen.
Yes, Dr. Virendra, please go ahead.
Yeah, this is a very interesting topic, and I want to ask the successful persons who are running the group, because see, since 2017, you know very well, we have been trying to motivate and increase the remuneration of practicing anesthesiologists. And we are in touch, being national coordinator in every state, we have a PPF forum and all. And yes, agreed, individually, if you are competent, but still leave problem and others. And what about the exploitation, what is going on? So, like you asked from Dr. Shah, see, what are the initial problems? Like we have a good attendance today, like 175, and I wish we can motivate some of our practitioner colleagues to join hands for their better future. There is no doubt that if you have a group, you are at ease, not only your comfort, but professional comfort, your family comfort, everything is there. So Dr. Shah, when you started a group in Ahmedabad, what were the initial problems? I mean, what was the hesitation, or like people think everyone should be equally competent, monetary issues? So what are the initial hurdles to start a group practice?
Dr. Virendra, you have put a very nice question, and we'll come to Dr. Shah a few minutes later. Let's first listen it from Dr. Subramaniam. I think Axon Group is the first one probably in India to start the group practice. So let's listen from the chief's mouth. And sir, your experience of starting and maintaining group practice, I think that will cover some aspects. And then we'll come to Dr. Virendra, your question. So Dr. Subramaniam is director of Axon Institute of Hyderabad, and one of the earliest group, I think the first one in India. Your experiences, sir?
So I think the first speaker was very eloquent. He sort of said a lot of things which I share with the advantages of a group practice. Now, coming to the nitty-gritty of starting, in a way, it was easy for us. We were 4 good friends in PGI Chandigarh. We were all together. 3 of us were in the same batch, and the 4th one, Dr. Gopal, was senior to us. And it was a dream that since we all belonged to Hyderabad, we felt once we complete, this was, I'm talking of, I joined PGI in 1988. So I finished in 91. And the desire to work together was there from then on. And all of us went abroad. We had our individual trainings, and, we all came back at different times actually, but the thought never went from our mind. And I came back in 2000. And TVS Gopal was here. He had come back earlier. So 2 of us were the first to kick off. And then Krishna Prasad and PVN Gopal joined. So the aim was manifold. One was to share our experiences and expertise. And this was also coinciding with corporate hospitals expanding in India. I think before 2000, I knew a lot of doctor colleagues who came and left India saying that there was no good platform to practice, and they felt frustrated with the sort of private practice and small hospitals. So we had a bigger canvas, I should say. The corporate hospital growth kickstarted somewhere in that time when we started our group. And also there was a desire to do more complicated surgeries. For example, in Hyderabad, the first liver transplant program was started by us. A global hospital was very keen to start liver transplants, and they were very happy that 2 of our seniors were trained in liver transplant in UK. So we actually brought that technology here, and that's how we shared each other's skill sets. And initially, when we started, we had just 2 hospitals. And we used to do on-calls as a common, for all the hospitals. And then as we grew, then we created a team for each hospital, and each hospital had its own sort of a HOD and everyone. But we still share work and responsibility. I think one of the key things in starting a group is trust with each other. You should have trust that everyone is working for the common good, and not have a feeling that someone is cornering some either not working and sharing the benefit, or that somebody is getting more remuneration than others. So there first has to be a trust among the original founders, and there's ways of making the group grow. We allowed more partners to come in. We were only 4 of us when we started, and now we are 10 shareholders in Axon. So we allowed our junior colleagues who grew with us to become part of the group, so that they also have a stake in the growth and the activities of the group. And I think we are the only group, correct me if I'm wrong, but who are present across different cities in India. I mean, most groups I know are usually limited to 10, 20 anesthesia doctors, maybe a little more, but they're still only in one city. And we have managed to grow beyond Hyderabad, and we are now in 4 cities and aiming to grow bigger. We also have, to make this possible, we need a good admin team. So just like a hospital needs a CEO or, finance person, HR, everything, we also have everything. We now have something like 180 anesthesia colleagues who are part of our group. Now to manage finances from different hospital, payroll, everything, it's not possible for us to do it on our own. So we actually have a full-time CEO for the group, Dr. Murthy, who is a cardiac anesthesiologist, and he's done management, and he's now the sort of a CEO for our group. And you need this kind of thing to make, other activities, because we can't look at the needs of individual associates. So you need an admin team to make this happen. And also to ensure that whatever you have billed each hospital is being collected, and that payments are coming on time. So it's a full responsibility. So I'm sure every group has in some form or the other an admin team, but we have a full-fledged team. We have an office, we have a CEO, we have a finance guy, we have an HR guy, and we have other staff to take care of all this. So any other aspect I have missed, I'm willing to chip in as we go forward.
Right. Thank you, sir. Dr. Sunil Shah, please, over to you now. To the question which Dr. Virendra Sharma has asked, and you are also running a group of around 50 anesthesiologists in Ahmedabad. And what Dr. Subramaniam has said, is there any difference between their practice and your practice? And I request you to take both the questions one by one.
Yeah. Okay. First of all, thank you for inviting me. And I'm totally agree with the Dr. Subramaniam. What is his plan? We are absolutely following him. And the advantage of that, so I mean, the first thing, what the problems we face, because we are ready to share the knowledge, but we are not ready to share the finance part. That is the biggest hurdles initially, but once we need to try to convince the person. And see, one more thing, when you go little, because we have our own company, so we have our own office, and like Dr. Subramaniam says, you should have one good administrator. So he is doing absolutely administration job, tackling the hospitals and the some anesthesiologists partners issues, and so many issues are there. So one person it's a full-time job. So there has to be a provision of the finance from the total collections. So that is very important, why we should give certain portion to the administrator. So because he is not doing anesthesia practice, like we have Dr. Maulik said, he is not doing anesthesia practice, he's looking after the creator's anesthesia administration part. And that is very important. I would say that is a key portion to run any group. Like we have advantages like Dr. Vivek says, that is all okay. And additional, I want to add one more or two, because we have only a one life, So we want to live a king size life. Now we as the Gujarati people, not totally 100% focus only on anesthesia. We have other interests also, like everyone has other interests. So in the group, we have achieved, like we have our own matrimonial site business, Shanghai. We have our own IT department where we make the softwares and all that. And now the Dr. Maulik is entering into the hospital management. So these are the other avenue which we can think. But primarily as an anesthesiologist, we cannot think. We can think only how to earn from the anesthesia. But we have our own other capacity. Everyone has that. But in the group, this is the opportunity we get. So if the understanding, the trust and the transparency, everything is required. Otherwise, group is not possible. So, and our company, like, initially there are 2 or 3 different types of, like my next question is that, like, what are the types of group? So like one is company and the other anesthesiologist work as an employee. And other thing is company is there, but everyone is partner, in some or sort of thing. So they don't get the set of salary also that on the work basis. So there are different modules are there. Some other groups is non-company, there is no company, then there is a group, they share the income and the share because there is a small group. But when you want to go a larger group, you should have a company and the certain philosophies and certain norms. So that is required. And we are since last 12 years in the group practice, and I'm very happy. So whatever we have decided initially, like that is almost 50-70% we could achieve. And still everyone is happy. We are tackling 30 hospitals and nearly 45 anesthesiologists are working with us. So that's a good size. Thank you.
But my question to all the panelists is straightforward. Suppose I have done my MD and a 1 year or 2 year of senior residency in a medical college, and I come to either Gurugram or come to Ahmedabad or to Hyderabad, and I approach you. As simple as that. So what are the opportunities for me as a second year post MD 2 years? Anybody of you can take this question. Let's make it practical.
Yeah, like
all have said that my second part will be very clear.
Yeah.
If group practice is so good, then why it is not prevalent in majority of the cities? Why it is restricted to the few cities? So first, suppose first question. Okay, I am a second 2 years, 1 or 2 years post MD, and I approach you. So what is an offer for me?
Yeah, I would like to answer this question because we are facing a lot of hurdles in this. Because like right now, even though we have a group, but we are in the competition with the individual anesthesiologists, and individual anesthesiologist can easily get the work even if there is a no group. So he can get these calls and all that. So his mindset is not, I would like to join the group. So whenever newcomers are coming to us, and we try to explain them that once you join, you have to work full time. We are asking what are the types of you want to work. If you want to do full time, then this is the options. If you want to do a part time, then these are the options. But initially, yes, if we have all the groups have a different policy. We have we can take depending on the availability and the work we have. But we can accommodate the things. Right now, we don't get anesthetics because we are in the scarcity. We have work, but we don't have anesthetics. Only thing the mindset is that
sir, Gujarati ho sir, kaisa kitna milega ye batao sir. How much remuneration will be there for a second year? Audience is interested in that. I have passed from medical college. I have done 2 years of senior residency, right? Please, what is the minimum assurance for me?
So in our group, we give minimum, if it is a full-time working, then start with the 1 lakh rupees per month. And depending on the work, he will get. If he gets more work, he will get more. So there is no limit, or we don't keep anyone in the employee. So he has a chance to grow from the day one. Certain juniors are earning more than me, even if I'm telling, because I have decided to work limited things, So they are earning more than me. So that is possible in our group. If you do more work, you get more things. And the thing is, he has the assurance of some certain works. Certain works we have to develop together. But like whenever newcomers join, he starts with the 1 lakh rupees.
Dr. Subramaniam, your insights into that. Yes, Dr. Virender, please go ahead.
One specific.
Yeah.
Yeah, please.
See,
Voice is breaking.
Sir, your audio is
monetary. See,
sir, your audio is cracking. By the time Dr. Subramaniam clarifies, Dr. Virendra Sharma, please.
Yeah, one question. He's trying. One question is, suppose as a founder of the group, Dr. Vinny, suppose you have formed a group in Gurgaon. So you make a contract with the hospital that, okay, we'll be giving you 24 hours services irrespective. Now when, like Dr. Naveen is saying, fresher or maybe 1 or 2 years join. So how do you accommodate that? Like you have a responsibility to the hospital. The new joining person, the hospital surgeons or the owner doesn't know him, but they have a faith on you. So how do you accommodate, them, the youngers, what kind of work you give? Do you have any assessment method that whether I should send this person there or not, knowing very well some of these surgeons' nature and all? How you tackle all these things?
Dr. Virendra, we have a group of hospitals under our belt. The team was already there in the Gurgaon. Me, Dr. Saluja, Dr. Tarun, and Dr. Sanjay, we 4 were there initially. And then we sat on tea table many a times to make a single team. And many a times there are so many discussions and everything failed. But what pushed us to finally make a team, which is doing now very nicely in the Gurgaon, is that our goals were almost similar. Like we are almost everyone is of the same age group, 2 year plus minus. So one day we thought that everybody is going to having a gray hair or no hair. So it's better now sit down and find out a way where we can really do a good job, quality job with quality work and quality time also to the family. So as you said, if a younger person comes to us, slowly we have we have tuned our hospital administrator or owners that you should, if you want a quality service to be given to your patients, you should have a 2-tier system of anesthetists in your hospital. One is consultant and the other one is a 24-hour resident or SR or an associate consultant or an attending consultant. Till attending consultant, we keep them 24 hours on the floor. So we always have a place for a junior person who is coming with MD 1 year, 2 year, 3 year, 5 year, 7 year, whatever the year of experience they have. We always have a space for him. So we put them in our rota, which is basically seen an administration is done by a junior resident. A resident himself. They make a rota. The rota comes to us. We look after the rota and then we finally approve it, and then that rota is going on. If somebody approaches me that I want to join from 1st of next month, so what I need to say, I will just tell my rota maker that this person has came new to the Gurgaon. Kindly give him some duties, so that they start with the duties, 24-hour duties. Once they are comfortable with the 24-hour duties, since they are doing 24-hour duties, and once in a while, me, Dr. Saluja, or any senior, 4 or 5 people, they will come to know each of us in few days or few months. And then when they are working with us in the same OT and the OT which is adjacent to the OT, because we are working in hospitals where 2, 3, 4 OTs are running all together. Like everywhere it happens. So whenever they are working with us, they get confidence, and then the operating surgeon, they also get confident that the boy is doing good or the girl is doing good. And one thing is very important, that since most of our practice is obstetric anesthesia, we really need to cover them very well, because there is no chance that we can leave them uncovered or unprotected. So by slowly working with us in few months, they are prepared so nicely that even consultant surgeons, they said, sir, raat ko mat aaya karo, there is no need. This man is there, this boy is there, this girl is there, they can do it. So this is how they nurture, and we also get good, quality sleep sometimes. If there is a small DNC or something like that, they do it by them themselves because they are qualified. They are qualified to do it. In fact.
Thank you, Dr. Vineet. Dr. Subramaniam, sir, the question which was there are two questions to you.
So, I know. It was about what we are. So I just want to give a background.
I think sir is again disconnected. Dr. Vivek, another question which usually comes is, sir, I am recently married, I delivered a child, and my baby is 6 months old, and I cannot do night duties because I have to take care of my kid also. And if you can just place me for the day duty. This is a common question which comes up with the young females and young colleagues. So how do you, because encourage them to be part of the group also and simultaneously taking care of their needs as a mother also. Dr. Vivek or Dr. Sunil sir, anybody can take up this question.
So what we do is we have at least 2 members who are in such a situation. First of all, let me, for your earlier question, I would still suggest to all the residents, please complete 3 years senior residency. You never know when you might have to take a government job. Life is uncertain. For 1 year, don't waste that opportunity. So my message is even now still there, complete 3 years of senior residency, please. It will train you. It will give you opportunity afterwards when you don't know. You might have to join government service, and those 3 teaching years of experience is all the difference that it makes. But if you're coming into practice, you are a young mother, you have to look after your baby. There are opportunities where we provide you 8 to 5 or 9 to 5 slots. There are many hospitals who still operate in decent operating hours and they finish their work at that time. What we do is when somebody new comes, there is always a senior person with that junior holding their hands, telling them that this is how we do the work. This is how you're supposed to approach the patient. I still remember the words of Dr. Anil Gurnani, who told, when I told him that I was going into practice, he said, Saluja, always work as if you're working in an institute. The standards have to be the same. If you feel that the standards are not met, say no. Nothing will happen. You will miss one case, but the rest of your life you will not be bombarded by a court case. So all newcomers, we give them an opportunity 9 to 5. There are many hospitals where they can go. For the first 2 months, there is a senior consultant with them holding their hand, getting their trust and showing the surgeon that the person can work.
But sir, suppose some issues which come up. Dr. Subramaniam will join.
Yeah, I'm sorry. I'm really sorry. Some issue with my connection. So just what I wanted to say was, a lot of our hospitals, we have been very active in teaching. So we have developed fellowship programs, DNBs, in whichever hospitals we are, at least the bigger ones. So a lot of the fellows who join with us for fellowships or DNB, so we have an arrangement with the hospital that the group pays for them. So it's part of what is our understanding with the hospital. And secondly, we have teaching program of Axon. Every Saturday for the last 20 years, we've been having a class like in PGI, how we had, an academic session. So I think there is a preponderance of people who like academic activity who come to our group. So it's not just about money. We also encourage a lot of academic activity. And you know that a lot of our seniors are active in national conferences, as teachers and writing medical literature. So this is one aspect which is not emphasized in the typical private practice. And I agree with other speakers that there is more money for individual private practitioner than in the group practice. But there are a lot of benefits which Dr. Saluja spoke in the beginning. So one has to choose whether money is the most important thing or the comfort of the group and the protection. Now, our group, we offer a group indemnity insurance So we have a 2 crore insurance policy for all members of our group. So if there's any litigation which is ever increasing, they're all covered. Second, we also offer medical insurance to all our colleagues, including their spouses and dependent parents. So these are some of the perks. Then we give a conference allowance to our colleagues. So every year worth 25-30,000, you can attend a conference and claim, the funds from us. So these are some of the perks we have added apart from the salary, and we have in every hospital a tiered system like in the institute. So nobody is on their own. We have a registrar, there's a consultant covering the registrar, there's a head of department if there is a problem. So it's a tiered and a comfortable work structure. There is a structured leave. Everyone has 20 or 24 days when they join, and seniors get some more leave. There's a conference leave. So it's unlike a private practice where you're on beck and call every minute of the day. Here, your work is very structured. So there is a payoff you have to do for that. You cannot get the same money which you get per case when you do private practice in a group.
Sir, coming to that aspect, suppose the medical legal issues happen. So whose responsibility is that? Is that of the individual, or the group takes up the medical legal issue as a whole?
Yeah, the group takes up the medical legal aspects. So that is an implicit understanding from the time they join. There is a group indemnity. Sometimes out of court settlements happen, and even that the group has ensured that we deliver on that and don't from the individual anesthesia doctor. But thankfully, in our 20 years practice, we've had only 2 instances of, at least people raising practice cases, and though most of them were frivolous, we settled them.
Right.
Naveen?
Yes, Dr. Vinender, please.
One question which I was reading, it's interesting. Like the success models which I'm seeing here, most of them started with like-minded and almost equal seniority, maybe 3 or 4. Now, suppose, Dr. Shah, you are a senior person and you want to start a group practice in a city. I mean, you don't have your batchmates or near about people. So what idea you would like to give to so many of the practitioners who are attending this webinar? Say, suppose in Lucknow, Kanpur, I don't have friends. They are all professional colleagues, maybe 5 years junior to me or 5 years senior to me. So how can I start group practice in my own city? Can any of the panelists give some idea?
Yeah, initially you can start. You can find out the like-minded person, 2 or 3, and share the idea of running the group. If they agree, then those works can be combined and you to start a small group. So initially, of course, 2-3 people required because there are a lot of things to manage, to getting the work and to convince the surgeons and the meeting with the other hospitals management, and so many works are there once you start group. So initially you need 2-3 same philosophy. Those who want to start group alone, you cannot start. I would not suggest that alone can start, but at least you require another 2 or 3 persons who can ready to do the group practice. So once they are ready, you can form a certain group and then you can start. So once you start group, so other anesthetists will definitely join.
Sir, 3 people have joined together. Now next step is, okay, 3 like-minded people. Suppose me, you and Dr. Virender are in Lucknow. And okay, finally we agreed, okay, we all feel that the group practice is very good after this webinar, and we plan to start the group practice. So we sat together and decided we want to start the group. What will be the next step?
The next step, I would suggest that you should form a company first, because the hospital will trust on the company, not the individual person. So if you have a company structure, doesn't matter you are 3 or 4, but if there is a company, the corporate hospital and the surgeon will look at in a different manners. And the anesthesiologists who are joining to you, because there is a transparency, the fund going to the company, and from the company they distribute to other things, So there has to be a company structure, and then you can enroll all the hospitals and the other doctors or other anesthesiologists.
So there will be some paperwork involved in formation of company that will be done.
Yeah.
Naveen, I just want to give my view here. Now, some people may find it difficult to go about starting company and all this. So we are very happy to help any colleague who wants to start in a city where we are not present. Okay. And give them the know-how. And if they want, they can be part of Axon and we can work out, what is their benefit and what is our benefit. And because we are already present across many cities, and we are very happy to encourage youngsters to form their own groups. And, I'm willing to help them if they want to be on their own or they want to be a part of our group in that city. So please, you can, give my contact to whoever wants to get more help on how to organize themselves on this.
I must place on record Dr. Subramanian is my senior in PGI Chandigarh and I am his junior. Sir, how much corpus it is required? Suppose 3-4 people start together. So how much corpus will be required initially?
So I don't think you require any money to start with because you won't start till you get some, and each of you already have some practice. So you just bring your practices into the group initially. But what we did was we cut down on our remuneration for the first about 3-4 years to build a corpus so that we pay our associates. Now, as Dr. Vivek was saying, not everyone needs to be a partner in the group. Now, there's different models of working. Now, in our 180 group of anesthesia associates we have in Axon, only 10 are partners. The others are our associates. But they all have the option to become shareholders. We have a structure. Some are interested to do that, some are not. And there are steps which they have to clear to be a sharing partner. So now we have enough corpus to take care because the company has done well over the last 20 years. But initially, sometimes we actually put in money. So the problem is not having, it's not that we don't get the money from the hospital. It's just the delay. The money you're owed comes after 2 months, sometimes 3 months, despite having an MOU which says you have to pay by the 2nd or 3rd of the month. And we are not in a position to enforce that strictly. But now it has got more or less streamlined. We also now have overdraft facility from banks. Because of our track record, banks have given us overdraft facility so that we don't have to put money from our end into the system. But initially, I agree that some amount, so instead of disbursing all the money you get, you have to leave certain amount and build a corpus so that it takes care of this kind of issues.
Absolutely fine, sir.
And certain amount.
Sir, if I may intervene 1 minute.
Please, Dr. Tanuja and Dr. Nilsha.
Yeah, for all the people who are in smaller cities, initially, I don't think we never formed a company for at least 3 years. For 1 year, you must work together and see if you're compatible with each other. The most important thing is that are you able to share money? The initial stakeholders or the initial partners, no matter what your level of earning when you enter the group, once you form the group, you have to have an equal share. Only if you have an equal share, will you be able to provide the commitment and will you give everything to the group. So some people will benefit, some people are going to lose. Like I lost a bit, my partners benefited a bit, but overall we all benefit in terms of the advantages. Work for 1 year, bring all your money to the table, share it. We, at that time, we used to sort of make arrangements with the hospital that the check used to be cut into 3 names, all the 3 names of our partners. So we used to get the money from the hospital in 3 checks. If you're able to do it for 1 year, then you think about starting a company, then you think about hiring associates. You will be comfortable to take slightly less money so you can pay for your associates. So the first thing is be ready to share your money equally. Make sure you can trust each other with the money. If the money is fine, all other differences are usually settled.
But sir, since this is about starting the company, but how you are distributing the money? The questions which are coming up in the chat box are, suppose other people join your group. So do you pay, like Dr. Nilsha said, that a minimum salary, then percentage of share basis, depending on the number of the cases. How do you distribute the money to the people who join your group?
So then
I would share my experience because we have come through all the different models. See, initially that is entirely depend on the people working into your company. See, like initially where Dr. Vivek said that 3 or 4 people has to be, mentality mindset like we will share the income. So no matter who is working or who is not, but you have to share the amount equally. So there is no question about it. If there is no 3 people or 4 people who are ready to share, then don't think about the group because it will not work. But then later on, there are different modules, how you share the income. You can initially you can give entire income, or you can keep some certain portion into the group. There are different models. That is depend on the individual. There is no fixed strategy because we have tried everything, and now we have settled that the people who work, they will take all the monies and different certain portions they will give to the company. So that is entirely different scenario. What type of sharing is there? But initially, yes, you have to share equally. 3 or 4 or 5 people, whatever are working, those who are a founder member of the group, they have to share income equally. That's what my suggestion.
So may I ask one question?
Yes.
Do you allow your associates to work outside the group also? I mean, joining your group as a part-timer and then working elsewhere.
No,
is that
not
allowed?
No, not at all. Because it is a diversifying interest. You cannot take such persons into the group. Okay. Everyone has to work. Whatever the income comes, it has to be into the group. So otherwise...
So that is a kind of commitment that he will not be working elsewhere.
Yeah, exactly.
Suppose the all panelists, suppose like you want to give a cover to the ICU 24 hours. You all are seniors, you can take rounds in the daytime and all. And you want people for night duty. There are many hospitals who engage anesthesiologists who are specifically interested for night duty because in daytime they can work. So what my question is related to what Madam asked, that he is fulfilling his commitment. He is giving you full night cover in ICU, working sincerely. Now, during daytime, if he says, I can earn more, why you are stopping?
No, that is a different story because he is not supposed to be a partner. He can work.
Not partner.
If he can work as an associate because so many anesthetists are working with us. They are doing only night duties. So we don't matter.
I will intervene. We have an experience of mixed model. Jo Dr. Virendra bol rahe hain. See, if somebody has done with the committed part of his job in the company, apart from that, if he gets something like from outside, some cesarean section, one DNC or one simple case, and if he wants to earn like 2,500, 3,000 rupees, 3,500 rupees, what's wrong with it? Let him go and earn. He will be having a smile on his face. Next day, he will be doing better for the company.
I think, Dr. Shah, yes. My question was for associates only. See, partners to everyone can understand.
Yes, of course, it's for the associates.
Partners cannot see if they divert their company will go. I was asking for the associates that if someone joins you.
Yeah, we can put an options, those who are working part-time or for the night duties, that is there, but they cannot be a partner in the group. I am talking about the group partner. They can be associates.
We have different system. We have partners in the group. They are the upper strata who are the founder member of the group. The second one is like associate, or we are dependent on them. Like they are the real good bunch of people who company can rely on really. And any kind of condition, any kind of hospital, with any kind of surgeon, with any kind of surgery. So of course they are paid very, very nicely. And then comes the junior most post, like people who are doing SR-ship, or they are just passed from the SR-ship. They came new to the practice. They wanted to see the hospital. They wanted to know the work we are doing. They wanted to basically train themselves under our situation. So of course they are also very handsomely paid. And as Dr. Naveen said, if a person like 2 years or 3 years of MD comes to the Gurgaon to find a job, I can assure them that we can very nicely offer them 1.5 lakh rupees a month.
Another one.
Yeah,
a VIP patient coming for emergency cesarean, who would take it?
Sorry, just
emergency cesarean, VIP patient, who's going to take the case?
VIP, there is no VIP in the clinical system. Clinically, there is no VIP. The clinical, data.
So for a
and
gynecologist, for an obstetrician, it might be a VIP patient, very close to that.
it's okay.
How do you tackle these situations?
Ma'am, sometimes you have to feed the ego of the gynecologist also. So you just go there and attend the patient. By the time, but of course, the patient cannot wait. If there is an emergency like fetal distress or something like that, somebody cannot wait for so long that you go from your home to attend that call. By that time, if the resident or the associate consultant there in the hospital, you can always check the blood reports and you start, I'm coming.
To add to Madam's...
No, but I agree with her. If I can interrupt,
please.
There are certain situations. For example, we have a very active epidural service. And if it's a VIP, the on-content go and place the epidural. So this is a privilege we have given. We have certain category of rooms which are, which the hospital for those generally VIPs are there. And there's a system where instead of the registrar of site, the consultant come if there's any procedure needed for that patient. And unless it's an emergency where the consultant can't reach on time, the consultants go and attend that. That it's not a clinical assignment, but it's a sort of a reassurance both to the. In fact, nowadays there are patients who are coming and asking that they want Dr. Subramaniam to be there during their and to do. I can't do it all the time, but so we should be proud that some people are asking for us these days. So where they were only asking for surgeons, they are actually asking for individual anesthesia doctor. There are some patients asking for seniors, not only in my hospital, in other branches. So you have a good patient. They will go and this anesthetist is good, and if you go and there's nothing wrong in trying to. If a surgeon can come for the patient's delivery, there is no harm in. If we can come, I agree. Not all every day, 25/7. That is not what we agreed to do when we.
I agree with Dr.
Anyway, by principle, we cover all our patients who are going to deliver by epidural analgesia or by cesarean section, be it elective or emergency cesarean section. The rule is consultant will always go and attend the delivery.
Agreed.
Yeah. The second thing is we are now pushing our hospital administrator or center heads to please make anesthesia services 2-tier system. The junior anesthetists will always remain in the hospital. So we are very nicely covered in terms of fetal distress or any kind of stressful situation for the obstetrics and patients.
Actually, what I wanted to add to Madam's question was remove the word VIP. Say, suppose there is a very high risk case, obstetric case. Now, I understand you have full confidence in your associates and senior resident. Still, the surgeon wants, look, I am worried about this case. So how do you manage that? Do you make a roster of 4 of you that, okay?
Sir, every hospital is covered by a consultant. So every day there is one consultant on cover for every hospital.
Okay.
If there is a VIP, if there is a sick patient, in fact, all deliveries are covered by consultants. In Gurgaon, where it is common that the patient will be having a BMW and you will be coming in a Maruti, there is no chance that you can not cover that patient. That is besides the point.
That is one of the biggest advantage of group. I would say it is the advantage of group. Only because of group you can have a free consultant attending the very odd situation, VIP patient or high risk patient. So individual it is not possible.
And all junior consultants, all associate consultants for epidural, they have to observe for at least 8 months. At least for me, before 8 months, I do not allow them independent epidurals. I tell them you have to have watched any consultant give at least 80 to 90 epidurals, and then you'll understand that you can give an obstetric epidural. Because the thing is that we are dealing with patients who are paying for our services, and we owe them a commitment that they're going to get the best care possible.
Right.
So this is the training that they receive.
Definitely. Dr. Kaul, you wanted to make a point, and then I'll come to Dr. Atul Gandhi and Dr. Madhusudan Paul. Dr. Kaul, sir, please.
I am afraid my comments may not be liked by the majority of the panelists over here, but I feel that I must speak it out. I was under this impression that the topic of the discussion is group practice. But what is being discussed is anesthesia corporate sector. A corporate sector where 140, 150 anesthetists are in the corporate, in a group. That doesn't make it a group practice. Group practice means that where 4, 5, 10, 20, 15 people join together and form a group to cater to the needs of various hospitals or nursing homes or like that. If you have a group of, say, Dr. Subramanian was saying that I have a group of 150 anesthetists, it becomes more than a teaching institute, double the strength than in a teaching institute. So in such a way, it means as if one is going to have a job in a private or a government medical college. In my opinion, a group practice would mean where anesthesiologists of say 10, 15 or 20 would meet together and cater to the services.
Sir,
that is my feeling. I am sorry if I have...
No, nothing at all like that, sir. Right now the panelists are, there are Dr. Vivek Saluja and Vinit Gupta have got 6 persons in the group. Dr. Sunil Shah has got 50 people in their group, and Dr. Subramanian has got 180 people in their group. So it is all the three. I'll request one by one. Dr. Vivek Saluja, quick reply to sir's comment, then Dr. Sunil Shah, and finally Dr. Subramanian. Dr. Vivek, please.
Sir, we are 6 anesthetists, and we have 3 are partners, 1 senior consultant, and 2 juniors who are there with us, who are about to become full consultants. So we started off with 3, and the method that I said, 6 of us provide services to about 14 nursing homes and mid-sized hospitals. We are joined by Dr. Vineet in many hospitals. He has a group of 4. So if you want to combine, that will make us 10 together. So we are by definition a small group. Together we combine to give services to about 25 hospitals. And it is because the 10 of us have combined that 10 people are providing services to 25 places.
Right, Dr. Sunil Shah, please.
Yes, I totally agree. That group, when we call a group, it is a number of people, same like-minded, and they are working together. But once you reach to about 10 or something like, you require a lot of administrative work, so that you have to have certain format or certain administrative work. That is why this kind of arrangement is required. Otherwise, group is what you are like is same. That is the group, irrespective of the number of the people, 10, 15 or 20 or 30. But they should be the same like-minded and the philosophy what they are working. Then only they can stay in the group. Otherwise, no one can stay in the group. So emotionally or socially or the philosophically, you are absolutely right. When we call a group, it is the same anesthesiologists working together, But for the administration person, you require certain things, depending on the situations.
Done. And a quick comment, a reply from Dr. Subramanian, sir.
Yeah, so like any business, eventually a group practice is a business. So no business wants to be static. Everyone wants to add to their business. Be it Uber or be it Apollo Hospital or be it a group practice. So the natural trajectory for anyone is to add more people, to add more hospitals. Now, let's say you are 6 people and you can only do so much. Now, let's say 2 hospitals come and say, we want your group to provide services to us also. Are you going to say no because we don't want to increase our number, or will you add more doctors to your group and provide more services? So we chose the path of natural growth. As more hospitals were asking for our services, we kept adding more anesthesiologists and we were providing our services to a wider segment of hospitals. So I don't think there is anywhere a concept that if 10 is a group and 100 is not a group. A group is a group, whatever is the number. And I agree that the sharing partners should be like-minded.
Can can I intervene just one point, please? What will be the incentive for the corporate hospitals to attract, to have the services of this group? If it is a corporate hospital which has a bed strength of say about 500 beds, why should they not have their own departments? That would be more lucrative, more helpful, and more profitable to them. What attracts the corporate sector, corporate hospitals to these corporate anesthesia services?
So if I can answer, more than 75% of our revenue is from corporate hospitals. I think it's a value proposition. We are all extremely qualified people and we give good quality of anesthesia first. Second, we develop teaching departments in the hospital. Third, we provide seamless cover. Now, let's say a particular corporate hospital, let's say Apollo Hospital, just for the sake of its name, has 10 anesthetists in the Delhi hospital and 2 anesthetists quit for whatever reason. Now, till they get 2 more, the 8 have to share an extra burden. And maybe some lists won't be done, or, you know, there is a time gap before they get more fresh anesthesia doctors. Whereas in the group, the advantage for the hospital is we are committed to provide a certain number of consultants, registrars, and no matter who stays or leaves, we have to provide that. And we do that. That is the value proposition we give to the hospital. And second, we give extremely good quality clinical care because we have so many associates in other hospitals. If there's a difficult case, I lean on the knowledge of my other colleague in another hospital to enable me to do that case better rather than refer that case away from this hospital. So there are many such ways in which you can make yourself endearing to a corporate hospital.
I think, sir, we have discussed in details the overall that it is you may start with a smaller number, but eventually, as per the need, you may grow as big as possible, and depending upon how much your company can take the load and how much you can effectively and provide safe and effective anesthesia services. Dr. Atul Gandhi, please.
Thank you, Dr. Naveen sir. Just I'm 100% agree with the group practice. Nowadays, it's a very essential, and above the age of 40 and 50, that group practice is a far better than the other practice. But my question is other side of the group practice. That's one of the disadvantage for the private practitioners. As group practice से क्या करते हैं वो लोग अलॉट करते हैं स्पेसिफिक एरिया में जाके बोलते हैं कि आपका कितना बजट हुआ, इसके साथ से कम में बात कर रहे हैं. तभी हम जो प्राइवेट प्रैक्टिस में जो बात कर रहे हैं कि मिनिमम चार्जेस, तो नंबर ऑफ टाइम्स ऐसा लगता है कि ग्रुप प्रैक्टिस में ये चार्जेस कम हो जाता है और दे कैन टेक ओवर दिस प्रैक्टिस आल्सो. That is one of the side effects of this group practice. This is a really practical problem.
You have raised 2 issues. One is that it may eat into the remuneration of the freelance practitioners, or if you join the group, you get less paid. I'll take 2 more questions which are coming in the group. What about the ego issues and exploitation of the juniors? Right. So I'll request all the 3 panelists to address these points. One, do we, Dr. Ganesh has also written, do we eat into the remuneration of individual freelance practitioners? Is there any exploitation of the juniors? And do we get less remuneration if we join group? Honest replies from the panelists.
So let me start. What do you mean by eating into a private practitioner's remuneration? Now, I think that's a very wrong way of putting a question because if not a group, one more private practitioner will eat into another private practitioner's practice. So I don't think there is any boundaries which should not be crossed. I mean, let us say there are 5 private practitioners in one area of a city. Do they agree not to poach each other's hospitals? If hospital which is being serviced by X doctor, if that doctor doesn't respond to the second phone call, they will call a Y doctor. That is a very natural way for any hospital to ensure that they get good service. So whether it is a group or another anesthetist which takes over their practice, I don't think that is a what should I say, an allegation which should be put on a group practice. That's very unfair.
Right.
If there is a good
Sorry. I am not going for the allegation. My question is,
Dr. Atul.
Yes, I want to clear it. My question is, this is fair? If you go for the less charges and then taking over the whole practice, and the private practice are number 6 or 7, they are going there, then they take over the whole practice. Is it fair?
No, I'm not talking of remuneration at all here. There are many reasons why a group may be hired over an individual doctor. So remuneration is one aspect of it.
Dr. Naveen,
please go ahead.
Just want to add. Dr. Atul, just try to understand, see what you are saying, maybe you might have seen, but what I could judge with the panelists sitting here, I think, see, these are the people who are in demand. And I doubt to run a group, if you decrease the charges, it will be very difficult to run the group because you have extra administrative expenses also apart from paying to the colleagues. So it's very difficult. I mean, see, I can imagine what you want to say is hire as many younger anesthetists as possible, try to capture the whole city and give them a fixed amount, maybe 1 lakh. You are trying to say like that model, but I'm yet to see such a model. What it is described here, they are one of the cream of their places. I mean, Dr. Subramaniam, 4 of his colleagues coming from PGI Chandigarh, then training in UK and all, Dr. Saluja. So how they are going to compromise for the money? Why should they? Why should they?
Sir, Dr. Gandhi, for a proper group practice, I often tell my surgeons I have to charge you at least 1.5 times the normal person, because I have to charge for the time when you're not going to call me and I have promised to provide you services. It is not possible to run a group by charging less.
I think Dr. Atul and Dr. Atul and other who in the chat box, I think there is nothing to be fearful of a group or any fear factor which is going to come. Okay, this group is coming up, because whether you start as a 5 persons, 2 persons, 3 persons, basically, as I rightly said, that initially you are going to sacrifice.
Yes.
You are going to see. All the panelists have said in the first year you are going to sacrifice your income. Somebody is earning high, he will settle for low, and somebody is earning low, he may get some advantages. Then you have to approach the hospitals, whether it is a nursing homes in a city or it is a corporate hospital in a bigger city. The hospitals, they are also not fools. They will also know the competency of this group and the anesthesiologist. Then your brand value comes in. Okay, this group will take care of the technically difficult cases also, will take care of the sick patients also, and will provide evidence-based medicine care. You will start building up your reputation. And then once you have done so, you have invested so much time, you are not going to compromise on the money. As simple as that.
Yes.
Because plus the persons who are joining the group, they are being supported clinically also, academically also, and professionally also, in addition to the personal and family support. So everything takes money. So I don't think group practice means charging less, right? So they will be charging appropriately. And yes, it is a natural thing. If particularly some people are doing good, the hospitals will call them. Hospitals will call them. But at the end of the day, you should realize that once you are in a group, how much stress-free your coronaries are. See, you can do n number of TM joint accuracies, you can do n number of FOBs, you can do n number of labor epidurals and high-risk PH cases and other ops cases, and you can be clinically, professionally certified also. At the same time, you are secure also. Plus, you get good money also. So I think Dr. Vineet wanted to say some point. Dr. Vineet, please.
I just wanted to add few more points, Dr. Atul. It's not about charging less. One thing, we are charging very handsomely, and we are famous for charging really maximum in the Gurgaon city. We, Dr. Saluja, we never compromise on the charges. One thing.
That's good.
It's not because of less charges we are asked for. We are asked for the value-added services we add to our group. like we are not only giving the anesthesia services, we are providing them infection control committee. We are providing them designing and making them their OTs and OT block in a most scientific manner. And we are providing them quality assurance. We are providing them auditing of their documents. We are providing them medical legal assurance and compliance of those medical legal compliances. So me and Dr. Saluja are in many committees of the different hospitals, and that services are absolutely free. So it is not only we are not decreasing our anesthesia charges. Anesthesia charges are never compromised. We are the highest paid anesthetists in the Gurgaon city branch. In the Gurgaon, even the big corporate hospitals, the consultant anesthetists are not getting what we are getting. We are not going to disclose our income, but we are very handsomely paid.
Done, sir. So,
thank you, sir. I want to just discuss another part.
Dr. Atul, let's quickly take up the questions coming in the chat box, then I'll come to you. Dr. Neha, please take up the questions.
Yes, so there's been a question coming up. How often and why do the members of the group resign? What is the basic reason and why should they stay? That is a question that has come up.
Nobody has resigned from our group. Everybody is still there.
Dr. Subramanian, would you like to take that because it's a big group?
Yes, sir.
Yeah, so a lot of juniors some come to us only for a limited training in a particular subspecialty or for a fellowship, and by design they leave after that program is over. And I think whatever benefits we may offer, there are family issues, there are personal issues.
I give a beautiful example.
Everybody. So
there is a boy working with us, and he belongs to Bangalore. He wants to go back to Bangalore, but he said, I just don't want to leave you, and I want to work with you. So we give them an option that you can work in Bangalore, but you can come 1 week in a month to work with us, and he is okay with us.
That is how we're supposed to make it work out.
We don't leave them at all.
So the question actually precisely was that what makes them leave actually? It's another question that is.
They don't leave us.
Right, sir. Another question that has come up is who is fixing our anesthesia fees? Is it by the anesthesiologist or is the corporate?
No. Once you are part of the team, your anesthesia charges or your monthly remuneration will be decided by the team, not by the corporate. Whatever we get from the corporate, be it a zero amount or be it a 10 lakh, but they are going to get the same thing. The other thing, even if they fall sick, we don't cut their money at all.
Right.
They get their full salaries.
Sir, there's a question coming up that she says that I have heard the group leader takes more percentage of anesthesia charges of juniors. Is this percentage defined?
No. There is difference between a senior consultant or a director in the company and the junior consultant or a person who is doing SI duties. Of course, this difference is lie in the government hospitals also, in the medical college also. Professor's salary is not about the same as the assistant professor's salary. So there is the difference. That's a genuine difference.
So that can be compared to the practice where in a government medical college there is a hierarchy system and similar way.
Yes.
It can be.
I think more importantly, the juniors should realize 2 or 3 things. First, it is an opportunity to continue to learn, and you also get to learn with senior people. You get an income stability, and this income keeps on going up. You are supported both mentally, financially, and medico-legally. These things come into importance when you are in a big soup. And the younger you are, the more often you get into the soup. Also, you get to work at centers that have basic minimum facilities, and the equipment is also good. And you get time to adjust to the surgeon, and the surgeon gets time to adjust to you because you're backed by a senior person. Now, these are value-added services that you'll never get when you work alone.
Right.
Say, anyone is joining your group, do you fix that this much time he or she has to work, or he can quit at any point of time? Is there any minimum time that person?
So 6 months for us is a probation period where we get to see if we can work with each other. If in 6 months he is comfortable, he or she continues. If they're not, they're welcome to leave. We sign the actual contract only after 6 months.
Okay, 2 technical questions have come up. What are the protocols for the clinical management across the group to ensure good and safe practice? And how do you ensure compliance, especially among junior? Dr. Subramanian? Dr. Subramanian, sir, are you there? Ensuring the good clinical practice across the group, across the members. Dr. Vivek?
Yeah, first of all our juniors work with us for at least 2 months. And during that time, we get to know them and they get to know us. Secondly, your OT technicians are always yours. And we always cross-check from them to see how was the person working? Was he comfortable? We ask the scrub nurses. We ask the junior surgical colleague. In fact, I asked my own senior surgical colleagues, how was it? I said, I want to feedback. Whenever there is anything wrong, you let me know. The thing is, if you're a good anesthetist, the surgeon is usually a good friend of yours. I mean, that good friendship develops automatically. You don't even try for it. Because it is a relationship which has to be from both sides. So he asks us about their juniors and we ask them about our juniors.
Right. So final question is, what type of paperwork has to be done once you are dealing, Dr. Sunil Shah, with the corporate hospitals? Suppose you're tying up with some hospital. Is there any paperwork which has to be done?
Yeah, we have the MOU with the corporate where the remuneration, all that is fixed, but they cannot take, there is a clause, they cannot ask for other anesthetists other than from our team. So that sort of, and from our team, we have keep a clause, they cannot work independent to that hospital where we have exposed. So that sort of things we have to do. Otherwise,
one more controversial question has come up. Many times the private hospitals and the corporate hospitals, they hire senior residents working in medical colleges for night duties. Is it right? Because they are not supposed to practice outside the hospital. Comments on that. See, since I am from a government sector, if you're not allowed to do duties outside your government hospital, if you're working in a government institute which says that private practice is not allowed, as simple as that, if you're going at your own risk as per your own moral standards. Yes, senior residents are doing it. They are doing night duties in ICUs and then next they come into the OTs, but that should not be encouraged at all. If you are in a medical college which says that, okay, private practice is allowed, then you are at your, you can do it, absolutely no issues. So it's as clear as that. If you're in a government job, private practice is not allowed, better not to do it.
Right.
So my final question to all the panelists are Dr. Vivek Saluja, Dr. Sunil Shah, and Dr. Vineet Gupta. Then I'll invite Dr. Harjinder Kohli and Dr. Virender Sharma there for the final expressions. You are with so much experience behind you. Your pearls of wisdom and practical tips to start the group practice in a city. The delegates which are listening to us, we are overshot the time by 20 minutes. But final 2 lines from all of you, 1 minute each. How to start a group practice in a city, the practical tips.
Okay. First, like-minded people. Prepare to share the money 100%. Complete financial visibility and fairness. If the money is fair, you can work out anything.
Dr. Vineet?
For me, it's a journey from I, me, my to you, we, and we and ours. One thing. The second thing, your problem, my problem become our problem. The third thing is learn to share not only the money, but time, work, and authority also. In some hospitals, when you are working alone, you are an authority. But once you are going into the team, that the hospital is going to the team. Now, you are not the only authority in that hospital. You should digest that thing. You should have the capacity to digest that thing. That tomorrow, not only you, but your partner will be coming to that hospital. So, be comfortable with that also.
Thank you. Dr. Sunil Shah, please.
Yeah, I think those who wanted to start the group, they must have the certain benefit of the group, because otherwise they would not think. So looking to the benefit of the group, I totally agree that one should have the transparency in the income. So where initially we have the some sort of challenges where we have to show all the incomes where surgeons are not ready, but we have stick to that because all the incomes come through the check only. So that way we can create a transparency into the systems. and the trust automatically build when if there is a financial transparency, and the ready to share the income initially. That is very important thing. So there are the 2 points only where you can start group practice. Then depending on the area where you work, you can automatically learn how to negotiate with those problems. Thank you.
Right. Dr. Subramaniam, sir, if you are, I know there were some network connections. Final comments from your side. And by the time sir speaks, Dr. Hajendra Kohli and then Dr. Virendra Sharma.
Yeah, it should be actually a team concept. Growth should be looked in a holistic manner. The respect.
So I just want to say that juniors should have patience to start with. That is the first thing. I mean, if your aim from the day you finish your MD is to maximize your revenue, then group practice is not the way for you. You should have patience to do good quality of work. First of all, I think one of the tenets which Axon practices is there's no compromise. In fact, many small hospitals which don't have basic monitoring, we refuse to provide services there, because one of our things in the MOU is that these are the basic monitoring, these are the basic equipments which the hospital will provide. And if you don't provide those, we don't want to, because anesthetist alone can't, do any magic there unless the infrastructure also cooperates with you. So if you're not mad after money and if you're willing to spend some time, it's possible for everyone to build a very good quality group practice.
Right. Thank you. Dr. Kohli, please.
Yeah, I think group should be a team. It should be more of a teamwork, and a able leader needs to guide the group. That person should be able to guide the group and in a holistic manner, that everybody's comfort is taken into consideration, the trust, the transparency, and the overall growth should be covering many aspects. That is recognition of each member of the team, both in terms of income and academics, they need to be taken care of. And I think most importantly, trust, transparency, and making everybody comfortable in the group.
Right. Dr. Gandhi, you wanted to make a different point before final comment from Dr. Virendra Sharma. If you are comfortable, you can make that. Dr. Atul Gandhi. Unmute, please.
I believe in group practice. I am eagerly with 100% agree with group practice is the only answer for the give the anesthesia practice. So I am agree with all consultant. I want to just other part of the coin. Just for this example, not going in Gujarat, we are totally happy with group practice. Thank you, sir.
Thank you. Dr. Virendra Sharma, please.
Yeah. So my message to practitioners here, you have seen models, but yes, they are from big cities with high paying capacity. So my suggestion is to begin with, you don't form a company, something like-minded people. You initially make an understanding that, okay, we will help you in need of crisis, each other. We will look after your work when you go out. If you do this much, at least for 6 months to 1 year, I mean, this can easily be done in any city. That would be the beginning of your group practice in future. Thank you.
Thank you all. And it was a wonderful discussions over the last more than, I can say, 1.5 75 minutes or so. Dr. Shetty has raised hand. Dr. Shetty, please, before I conclude. Please go ahead. Unmute yourself. Unmute, please.
Hello?
Yeah, please go ahead.
Am I audible?
Yes.
Very good webinar, and it was a wonderful meeting, and I learned a lot about the group practice. What I was trying to see, that I also started this in my city. I have asked a junior consultant, and from February 1st, I'm enjoying a lot. I have asked him to share my cases. On Saturday, Sunday, I am free. This is on trial basis, and it's working very well. And he is now going out of station For 5 days, he is enjoying. And I attend the meetings. We have to build a confidence among ourselves so that we can enjoy our life. That's what I wanted to say. But faith building and to learn new things, you have to travel. For that, you need to have this bonding. So, with these words, I thank all the speakers, all the chairpersons, and all the faculty and delegates. And I congratulate Dr. Naveen for having this vision to have this webinar. Maybe we can have more discussions on next week. Thank you very much. Good night.
Dr. Naresh, sir, you wanted to say something?
Yes, sir. Good evening, everyone. Good evening, Dr. Kaul, sir. Sir, I have a question. How this group practice is better than working in a corporate hospital? Because in corporate hospital, you go to one place and make the same corpus more safe, more congenial environment. But in group practice, you run into the 3-4 hospitals all the time, most of the time on the roads. You don't know what kind of facilities are there in the other hospital. So how is it better than the working in a corporate hospital?
Sir, one thing I can tell you is, that if you're working in a corporate hospital, I'll take the city of Gurgaon. Nobody knows the anesthetists who are working in the corporate hospital in the IMA meetings. If you're a freelancing anesthetist or you're working in a group, there is nobody who doesn't know you. Second, I get very bored going to the same place every day. And if I don't see the sun for at least once in every 4-5 hours, it's really bad. So maybe for people like me who don't like being cooped up in one place, and I also like to meet everybody all over the city, I find that this group practice is better than working in a single place.
Some other aspect?
Yeah, basically it is entirely depends on the individual mindset. If you are comfortable with going to one place and you are working with the corporate, it's okay. So then you are not meant for the group practice. The group practice at the advantage is different. If you are looking for those advantages, then only the security and the comfort and the social life and all that. So then only the group is there. Otherwise, the individual practice is always better.
So I think one thing is very, very clear from the panel discussion, that running a department in a corporate hospital is an absolutely different type of anesthesia practice. And running a department in medical college is also different. Here, what we are discussing is that, okay, a like-minded set of people, beginning, everybody has started from 4, 5, 6, and then gradually built up. And then you keep on providing your services to different hospitals. You may become as big as 150 or 180, or you may be happy with 50, or you may be happy with 10. That depends upon your own group. But everybody here wants to strive this point that with group practice, you need to have patience to put in at least 1 year initially. You need to be having some sacrificial attitude, but ultimately you are going to get benefited in all terms, whether it is academic, whether it is clinical, whether it is financial, whether it is social, whether it is medical legal, whether it is recognition. So now it depends upon us how we imbibe from the pearls of wisdom which our 3 panelists from different parts of the country, North, West, and South have given us, and to incorporate in our day-to-day clinical practice. I am profusely thankful to all the panelists for sparing their valuable time. Dr. Subramaniam, Dr. Vivek Saluja, Dr. Vineet Gupta, Dr. Vinil Shah, and very, very dear Dr. Harjinder Kohli and Dr. Virinder Sharma for chairing the sessions, and young Dr. Neha for coordinating it, and Mr. Rahul Chaubey from Anaesthesia TV for streaming it across the different social media and the electronic media. See you.
Sir, happy birthday to Dr. Kaul, sir. It is tomorrow. In advance.
Yeah, okay. In advance, we wish happy birthday to Dr. Kaul, sir. Definitely.
Thank you. God bless you. Thank you.
There is a seminar tomorrow in Ludhiana on pain, and combining with the birthday celebrations of Dr. Tej Kaul, sir. Sir, wish you a very happy birthday in advance, and may you always live long, happy, healthy, and smilingly, and keep guiding us, blessing us.
God bless you. God bless you. God bless you. Always.
Thank you, sir. Thank you all. With this, we come to the conclusion of today's webinar. Thank you all.
Thank you so much.
Thank you. Thank you all.
Recording.